home of medicine podcast with me, Dr. Amy Burbridge. I'm a consultant in acute and general medicine working in the West Midlands. And over to you.
Hi, I'm Ben Lovell. I am similarly a consultant working in acute and general internal medicine, but working in London.
So Ben, I have a case for you. Are you ready?
Yes, very excited. Go.
Okay, so Ben, this is a case I saw a couple of months ago. I was working in the same day emergency department. However, it was a very, very busy week. It was sort of post-Christmas, sort of that winter pressures time. And actually, our same day emergency care unit had patients admitted overnight. So they were in beds in the same day emergency care unit. So it wasn't necessarily a patient who would have been a typical STEC patient. So I did a ward round in the morning, and just before I started the ward round, the night registrar had took me to one side and said, Amy, I've got a patient I saw overnight who I'm worried about. I'm not sure what's going on. I think it might be this, but I'd really appreciate it if you see him sooner rather than later because something's weird and I don't know what's going on. And I said, okay, yeah, no problem. And I got the patient's name, I got the location, and I proceeded to do my ward round. So I'm going to tell you a little bit about the story. He's a 27-year-old male, normally fit and well, no significant past medical history of note at all. He presented with severe bilateral calf pain. Severe. The worst pain he'd ever had in his life. And this had been present for around 48 hours. So it was the Wednesday. And he said it started around Monday, late Monday afternoon. And the pain was really bad. He'd tried paracetamol, ibuprofen, and nothing had helped take away the pain. He'd also noticed that he wasn't able to walk properly because both of his feet felt like they were dragging. And he said that his friends and family had also noticed that there was something weird in the way that he was walking. And his legs just felt a bit weird and they felt weak. Apart from that, he had no symptoms at all that had asked him about. So he denied a temperature. He denied any bowel and bladder involvement because I was thinking, oh, he's got this bilateral leg weakness. He's got pain in his legs, but he didn't have any bowel problems. He had no bladder problems. He had no arm problems. He had no aches and pains anywhere else. So all he really said was he had this bilateral calf pain, severe pain, plus he couldn't really walk properly and he didn't know what was going on. So I'm going to stop there. Any thoughts?
So my blink response, my system one thinking response is I want to rule out Guillain-Barré syndrome, acute onset neurology in the lower limbs of a young patient with what sounds like a sensory and a motor component. That's my initial gut. Now, my system two thinking is let's just slow down and work through this. What could be causing this? We haven't got to examination yet, so this is really vague stuff, but could it be vascular? Has he got either arterial or venous occlusion to the blood supply to his legs? At 25 with no past medical history? No, I don't think so. Could it be a vasculitis? Not presenting with calf pain, I don't think so. So that's vascular. Could it be neurological? It sounds it. I'm thinking of acute demyelinating polyneuropathy, which is, Guillain-Barré syndrome. So I'm going to go and examine him, look at his reflexes, work out if he has any, what the sensory issues are, work out what the motor issues are, and ask about any preceding potential triggers for Guillain-Barré syndrome, such as a diarrheal illness or a respiratory tract illness. So that's my main thing. What else could it be? A myopathy, a myositis? Usually when you get a new onset myositis, it tends to be the big muscles. I'm talking quads and things. So unusual for big calves. Could rhabdo present like this? Why would he suddenly get rhabdomyolysis of his calf muscles? But maybe a CK is worth checking. And anything else it could be, we've sort of gone into musculoskeletal territories. But that's where I am at the moment. So I'm super keen to know the examination findings with a specific focus on neurology.
Okay, so before we move on to examination, is there anything else you want to ask in his history? So you've talked about any preceding illness, anything else that, given the conditions that you've just listed for me, any other questions that you want to ask to help rule in or rule out those diagnoses?
So we've asked about past medical history and he said none. any risk factors for any vascular issues? I mean, I don't know. He's not got bilateral DVT. So actually, I'm not even going to ask that. I don't even want to know if he's got risk factors to DVT. But you asked about triggers for GBS, any medications you might be taking for medication-induced rhabdomyolysis, including alcohol and recreational drug use, HIV status, or risk factors for that. And I mean, it's not sounding to me like a cord lesion, but I don't have enough data to say yes or no for that. But any recent trauma or back pain that might point towards a sciatica or radiculopathy would be useful to know. I can't think of anything else.
No, okay, so you sort of went down the same thought process as me. So regarding the back pain, he had no back pain at all. He'd had no back injury, no back trauma. From the Guillain-Barré perspective, he'd had a bit of a cold, but nothing that would suggest a diarrheal illness, and nothing that was hugely out of the ordinary with regards to the cold, the coughs and colds that everybody sort of gets in January, February. You mentioned earlier on about a vasculitis, and yeah, we thought this is weird. I always think vasculitis, but there was nothing. There was no rash. There was no hair loss. There was no respiratory problems, no chest pain. It was so acute. It was literally a couple of days. The only thing he did say was that he played football on Sunday, but that he normally plays football on Sunday. And actually, he wasn't feeling very well, so he didn't play football for very long. So
I mean,
that was it, really.
Very well. With his cold, or
with his cold, yeah.
Okay.
Yeah, but nothing. I probably wouldn't want to play 90 minutes of football in the cold if I had a cold. So nothing that I was hugely concerned about. So let's go into the examination. So on examination, he was in bed. He was sitting up with his legs out in front of him. He looked well, but he looked tired. He said he hadn't slept the night before because he was in quite a lot of pain, and also it was quite noisy. So the typical sort of, hospital stay. Observation-wise, his blood pressure, heart rate, normal, respiratory rate, normal. So I was really interested in the respiratory rate because I was thinking about Guillain-Barré, but again, all completely normal, nothing of note. So I looked at his legs and they looked normal. I couldn't see anything that, there was no muscle twitching. I asked him to raise his legs off the bed. So checking his hip flexion and hip extension, he did that, no problem. Power was 5 out of 5. And when he did that, there was no back pain. So sometimes when you do that straight leg raising, but again, there was nothing there in the back. He was weeing and he was pooing okay in hospital, so not a concern. But he couldn't get to the toilet and he was having to use a bottle and a commode, slightly concerning. So we're going to move down to the lower part of the legs. So I went to look at his legs and I went to touch them and he screamed. He was like, it's so painful. And I was like, really? Like, this does make sense. And I was feeling them. They were warm to touch, but not necessarily out of keeping with, anybody else who'd been in hospital and wrapped up. But that was so painful, but they weren't red or anything like that. And they weren't swollen, which is, you'd mentioned DVT somewhere along the line, but there was nothing suggestive of that at all. So on neurological examination, his knee power and extension was normal. However, when I went to his feet, he had bilateral foot drop. He could not move his plantar flex or dorsiflex his feet at all. There was nothing. There was no movement. And I said to him, can you push down on my hand like you're pressing on the clutch? And he was like, I am. And I'm like, press harder, press harder. And he was like, I am. And I couldn't see anything, not flicker, nothing. So he couldn't move his feet at all. And sensory wise, it was just excruciatingly painful. So he did have sensation, but it was painful. So I then went to feel his pulses, and I started off with dorsalis pedis and I couldn't feel it. So I went to tibialis posterior and I could feel it. And I thought, I'm probably going to have to scan now, actually, just to make sure that his pulses are present. And they were. Pulses were present in his lower limbs. So I was happy with that. So I was like, what on earth is going on? This makes no sense. And what had happened sort of in this, when I went off to have a think, the night doctor had requested an MRI of his sacral spine to make sure there was no cord compression. So in the meantime, we had the MRI back and it was normal.
Okay.
So what would you do?
I am still, he's right. He has got an acute sensory motor neuropathy and it's peripheral. Only hands were fine, right?
Everything was fine in his body, apart from really his feet. but his calves and his legs were very painful to touch.
And were his feet also painful to touch?
Not as painful, but they were, they were not as painful as his calves. So when I was feeling around his calves, he was in agony, but lower down, no, they
Right.
weren't as painful.
And how high did the sensation symptoms go? Did they go above his knee?
No, no,
And
not at all.
excruciating pain, the whole lower leg, the shin and the calf? Or just the
Mainly the calf and around the back of the leg, but sort of, the tibia, where it's the fat part of the bone, and medially, there was no discomfort there, really.
but there was no muscle inflammation. And it sounds to me like you're saying touching the skin was excruciating. It wasn't squeezing the gastrocnemius. It was touching the
I
skin, right?
couldn't, well, I couldn't squeeze the gastrocnemius because I was in so much pain.
Oh, I'm still stuck on Guillain-Barré here. Or, I mean, I know there are subtypes of it, but it's an acute sensory motor peripheral neuropathy, which is not yet ascending, but has started at the bottom. And
Mhm.
this would be my number one diagnosis right here. You've done the MR. The next diagnosis I'd be thinking about, considering we cannot get same day nerve conduction studies, and would be a lumbar puncture looking for a raised protein, which would be in keeping with the diagnosis of GBS. I'm going to say GBS. I can't bother to keep saying Guillain-Barré syndrome, but that's what I'd be
Can I
looking
ask
at. Yeah.
why? So I'm just going to really do a bit of a deep dive now into your thinking behind this. So you've gone for Guillain-Barré.
Yeah.
Can I ask why
Mm.
you don't think it's a muscular problem? Why you've gone for a nerve problem?
Simply because the way you're describing the pain, um, I'm
Mhm.
imagining you resting a fingertip on his skin and him getting severe pain from that, which implies to me small nerve fibers are damaged.
Okay.
Right, you said you couldn't even put enough pressure on to get into the muscle. I'm not completely discounting that, and I still want to see that CK to see if there is any muscle inflammation or breakdown.
Mhm.
But I I will say the magic words. I've seen a case like this before, with a man came in with severe screaming in pain, and it turned out to have sensory predominant GBS, was the
Ah,
ultimate diagnosis.
okay.
So I've got a bit of a previous case bias here because it's flagged up in my internal library, a similar case. You imagine it running through my internal diagnostics. We've come
Yeah.
up with a
Yeah.
77% match, and I've matched it in my memory to this case. So that's where I'm thinking right now. I would, in parallel to my work at the GBS, be getting a CK and be thinking about doing a myocytic screen, autoantibody screen.
Okay.
But at the moment, that foot drop, the motor loss, I can't explain that yet with a muscular pathology yet.
Mhm.
And did you say his reflexes were preserved or not there? His
I was unable to get the reflex in the knee.
right.
I was unable to get, but to be honest, he was in so much pain. I probably didn't try hard enough to get it because I was scared of hurting him. Sometimes when you get that type of so
Ankle
um,
joints or similar?
ankle I didn't do.
And
Yeah.
plantars, plantars.
Plantar I didn't do. Oh,
So
plantar response. Sorry. That was normal. That was
down.
normal.
So it
Yeah,
still could
down going plantar.
still could fit. But there's my initial workup.
Okay. So what would you do next?
I've ordered my blood tests. I've ordered my CK. I want a
Yeah.
neurology review, sharpish, um,
Okay.
and I'd be thinking about probably very strongly leaning towards a same day lumbar puncture to look for abnormalities in the CSF in keeping with an inflammatory process.
Okay. So I can give you some blood tests then.
Mm,
So his white cell count was 7, so within normal range. His CRP was 118.
mm,
That was high. His urea was 5.
mm.
Creatinine of 86.
Okay.
The vasculitic screen had gone off, but obviously that's going to take a long time. So while we're waiting for the ANA, the ANCA, and all that to go off, his urine showed 3 pluses of protein and 4 pluses of blood.
Mm, mm,
That had gone off.
mm.
And we'd sent further analysis. So, you sort of, I was standing there and I was just kept thinking and going, what is going on? It didn't fit anything I'd seen before.
Mm.
And that's when I think you start to activate that type 2 thinking, isn't it? Because type 1 thinking, I have seen Guillain-Barré, but it didn't fit the typical Guillain-Barré. But it doesn't mean it necessarily wasn't that. It could be ADEM, as you mentioned before. So what else could it be? And it was bilateral. So I was thinking it must be something neurological because it's bilateral, something like Guillain-Barré. So the CK was sent, and I kept clicking and clicking on the result button.
Mm-hmm.
Didn't come back, didn't come back, didn't come back. And we phoned the lab to try and find out where it was. For some reason or another, on that particular day, this blood test had gone to a nearby hospital for analysis, which sometimes happens when there may be an analyzer that's not working in the hospital or something like that. So I kept sending CKs off. And by the time we got a CK result, about 4 came, because I'd sent so many that all of a sudden 4 came in quite quick succession. But
Right.
kidneys are fine, apart from the urine dip and the which showed blood and protein. So I phoned a specialty because I was worried about a particular condition and it wasn't Guillain-Barré. So I didn't speak to neurology.
Are you going to tell me the
And
CK, or we don't have it yet? No.
I didn't know it. So I'm going to put
Okay.
you in the situation that I was in. So
Yeah.
this was about 1 o'clock in the afternoon and I hadn't got the CK. And I got
Okay.
the patient in front of me. I got the urine dip. I got his U's and E's, which were normal. And I phoned a specialty.
Okay. So you've got a
For some advice.
nephritic urine dip. You've got
Yeah.
a um, a normal renal function and a normal fluid,
Mm,
not grossly nephrotic.
yes.
The serum albumin was tested as normal, or
Yes, normal. Yeah, liver function was normal. Everything was normal.
and there was no rashes anywhere. I'm thinking rheumatologically now. So
Nope.
I'm going to guess you
No
rang
rash.
rheumatology because you think this is an acute presentation of some very bizarre vasculitis, which I've never heard of. I don't. There you go.
No, I didn't ring rheumatology.
And I'm out. Can I phone a friend?
I didn't ring rheumatology. So I don't know. I was thinking I used to be many years ago a room reg, and I also used to be a bit obsessed with Anchor, less obsessed now as an acute physician. So I phoned trauma and orthopedics, and I said, "Hello, TNO registrar. My name's Amy. I'm the consultant in acute medicine. I've got a patient who's down with me in Esteg who I think has got any idea?"
I've got
Because they
no
left it.
idea where you're going with this. No idea.
Bilateral compartment syndrome.
Oh, okay.
Because you've followed me, or do you think I'm
Well,
on a
I'm with you now. I'm going back to what you said about you couldn't feel pulses at the beginning and the excruciating.
Mm.
They weren't swollen, you said. Did they look? They didn't look
It-
macroscopically swollen, no?
they weren't swollen,
Okay.
but the pain was so bad that it's the amount of pain he was in. I was like, this is it just felt compartment syndrome because of the level of pain it was. And
Okay.
I've never seen that level of pain with Guillain-Barré before, to be honest,
Mm.
or cold compression or anything like that. So I spoke to the TNO registrar and I said, I think I've got a patient who's got bilateral compartment syndrome. And they were like, doesn't, very rare, doesn't really, are you sure? And I was like, well, I can't explain it any other way. I don't know what this is.
Mm.
So he came down and they saw the patient. And I did something that I shouldn't have done. And I kept trying to sell what I thought the diagnosis was to the registrar to try and bias him towards my diagnosis.
What did you do, Amy?
Have you ever done that? Hmm?
What did you do? To
Well,
answer,
I was,
I have done that. Yes, yes. I've definitely packaged up and put a presentation on the
yeah,
case with certain orientation to match the expectations
yes.
of the listener that I'm trying to sell the case to. Yes.
And I was so convinced I was right. Like I had tunnel vision and nothing else convinced me of anything else otherwise. That
Yeah.
when when they came down, I was like, right, I know what's going on. He's got this, and this, and it did exactly what you said. I had this beautiful presentation, and they weren't convinced. I must say, they were sort of raised an eye, and they were like, well, it could be actually. What's the CK? And I was like, the CK's still not back. We don't know where it is. So we're still waiting for the CK. He went and saw the patient and was like, do you know what? You could be right, actually. I think this could be a TNO problem. I'm not sure what it is. I'm going to go and speak to my consultant.
Good.
Great. So in this time, we'd done a viral swab and everything came back negative apart from respiratory syncytial virus, which was positive.
But he's had a cold.
So Yeah, so I didn't know whether that was linked in particular to anything. But I was like, okay, we've got a positive result there, but his flu, COVID, they were negative. So
And
I
can
was
I ask,
pretty
did you
happy
have
with
any
that.
ideas about why he might have bilateral compartment syndrome at this time, in the absence of preceding trauma or surgery?
So the only thing I could think of was him playing football on Sunday with a cold, which didn't
Okay.
really fit. So he'd had no trauma, he had no fractures, he'd had no injuries. He denied alcohol and drug use
Hmm.
that could have maybe affected things, but he denied that. So the orthopedic consultant came down and we had a conversation, we had a chat, and I stayed in with him and I said, is it okay if I stay when you speak to the patient?
Hmm.
And by now the patient was there and all of his family were there and had a conversation. And he came out of the conversation, he said, I actually still don't know what's going on. Yeah, it could be something else. We still didn't really know what was going on. And by now it was around 5 p.m. in the afternoon.
Hmm.
So I'd seen him probably 6 hours before this on the ward round, and we were still waiting for tests to come back. I got some fluid going through because I was worried about his urine. I got pain relief going through. I didn't give him antibiotics because I wasn't concerned that there was any infection going on. And his CK came through.
Go on.
His CK was 24,444.
I've seen higher, but that's pretty impressive.
Yeah, I mean, I've seen higher, but it was pretty high. And I guess for the diagnosis that we were thinking of, compartment syndrome, due to severe underlying myositis, inflammation, rhabdomyolysis,
Hmm.
it sort of helps give weight to that diagnosis a little bit more.
Absolutely, yeah. Inflamed muscles. There is inflamed muscles that are breaking down and releasing
Right.
CK into the bloodstream. Yeah, that all ties together, doesn't it? We just don't know why.
Yeah, absolutely. We don't know why. Now, the difficulty here was because I'd been so focused on this diagnosis,
Hmm.
I'd not been focused on the possible diagnosis that you'd raised of Guillain-Barré.
Oh.
So what I didn't do was speak to neurology. I didn't do a lumbar puncture,
Hmm.
and I didn't go down that route.
We still haven't quite got to the bottom of the power loss, have we, at the ankle?
No,
Um,
no.
can't be I mean, even if his calves were about to explode with compartment syndrome, it doesn't fit with a compressive neuropathy. Um,
Mm,
we've done another episode of the podcast about foot drop and compressive neuropathies
yes.
and such like, and it shouldn't cause both complete 0 out of 5 at both ankle dorsi and plantar flexion. So that there's still some unfinished bits of the story that don't.
Mm.
Okay.
It doesn't. I guess it didn't fit any illness script I'd seen before. It didn't really fit any illness script the orthopedic team had seen before either. So by now we'd started to collaborate. And me and the orthopedic consultant had a conversation. We went into the office and said, okay, what about this? What about this? Do we need to speak to plastics? Do we need to do this? Do we need to do this? Because something's going on here that we're unsure of what's going on. So, but I was so blinkered into my diagnosis and convinced it was bilateral compartment syndrome. I was trying to convince the surgeon to take this man to theatre for bilateral fasciotomies. And he said to me, no offense, but you're not a surgeon. And I was like, I know. But I'd become so convinced, and it was really difficult to talk me out of that. But I don't know why.
Hmm.
Like,
Don't they have little probes that they stick into the muscle and that can measure the intracompartmental pressures?
they do, absolutely. So I'd had a conversation with the family and the surgical team, and I'd finished work a couple of hours ago, but I'd sort of wanted to make sure that, he was okay and we got a plan in place. And the plan at that point was for the gentleman to stay on the medical admissions unit at that moment. The orthopedic consultant was going to go and speak to all of his colleagues to get advice, which I think is an excellent
Nice.
idea. Actually, I probably should have done that earlier on in the day and gone to my colleague. But when there are, when you're busy or whatever, you sort of sometimes forget to do that. And also, I didn't want anybody to talk me out of the diagnosis. Does that sound?
What do you
I
mean?
know. Well, because if I'd gone and spoke to my colleagues and they may have given me something that was much more sensible. And I guess,
Surely that's a good thing, though, to give like good
yeah,
patient.
yeah, yeah. I don't know why. I was just, you have one of those days and you just get like a bit between your teeth.
Oh,
Um, and I learned a lot about myself from this case personally as well, in how I manage things in a stressful situation, actually. Um, so that's something to talk about at the end but at the end of the day, we have a 27-year-old gentleman with severe calf pain, with bilateral foot drop, a CK of 24,000, and a positive urine dipstick for protein in urine. So in my eyes, this was rhabdomyolysis until proven otherwise.
Okay.
So I went home after this because I was like, I'm going to hand over to the appropriate teams and I'm going to stop meddling. And when I went back in the next day, I'd noticed that he'd gone to theatre the night before. And documented in the theatre notes were his pressure in his compartments.
Mm.
And the pressure in his right lateral compartment should be less than 10 millimeters of mercury, and his was 140.
Oh, wow.
And the pressure in his left was 130.
Okay.
And the diagnostic cutoff for compartment syndrome is 30. So massively elevated
Yeah.
compartment pressures.
Yeah.
And the theatre notes and the description of the muscles is that they were very dusky in colour. There was a little bit of blood flow, but not much. And they released the pressure within the compartments. So the final diagnosis was bilateral compartment syndrome, most likely due to playing football on a background of being unwell.
Yeah.
There was no, yeah, I know. There was no other significant risk factors. He'd got no fractures at all, no trauma.
It's very
What do you think?
very unsatisfactory diagnosis, I have to say. I I don't like it, and I mean, I would struggle to make my peace with that. It does not. There's too many unexplains to me, you
Yeah.
know, for that. Namely, the absence of any sort of noticeable trauma enough to cause such muscle inflammation and such insanely high pressures within those muscular compartments and that degree of.
Mm.
You'd expect him to be run over by a truck over the back of the legs or something like that. You'd expect a bone to be broken. So I would hear that diagnosis and I'd say, well, maybe, but I don't
Mhm.
believe we have ruled out autoimmunity and other myopathies here before we call it all trauma induced. Would be
Absolutely.
my gut
Yeah.
feeling.
So I went to see him a couple of days later, and I saw how he was, and he was like, okay, but he had no movement at all in his legs, his feet, and
Mm.
he had pressure, only had drains coming from his legs, and I asked him how he was feeling, and he was like, I'm okay, I've a bit of a cold, and we talked about if he was okay if I discussed this on the podcast, and he said, yeah, absolutely, and subsequently he's been followed up and he's had some nerve conduction studies. And the nerve conduction study show evidence of complete axonal degeneration at the left and right common peroneal nerve palsy. They're completely gone. He has absolutely no power at all in his right and left common peroneal nerves. He wears foot splints, and he still cannot plantarflect or dorsiflex his feet at all. His autoimmune screen has come back normal, completely normal. And sort of getting back to work, trying to get back to normal after this quite a significant event in his life, having quite, significant traumatic surgery, to be honest. But I agree with you. Some things, and I think throughout it, and I think this is why I wanted to talk about it, something, I don't know, it's an unusual case, isn't it?
Yeah, it's I'm just trying to arrange my ideas.
Mm.
It doesn't make sense to me. So do they think that these bilateral common peroneal nerve um, axonal neuropathy is due to compression, due to the compartment
So,
syndrome?
yeah, so I went away and had a read about compartment syndrome, trying to think about what sort of pathological level sort of happens. And there is a massive increase in pressure, and it's a closed space, isn't it? A compartment. So if you've got inflamed, swollen muscles from maybe excessive exercise on top of a cold, for example, then muscles inflamed, but there's nowhere for them to go. Because there's nowhere for them to go, it compresses the circulation. So it compresses the arterial and the venous blood flow.
Mm.
So there is compression of those blood vessels, and because there's compression of those blood vessels, it decreases blood flow to the nerves. Now, that's very severe, but when I did see him, his feet weren't pale, they weren't cold,
Mm.
they didn't have, and he had good pulses. So, maybe I saw him at an earlier stage, and by the time we went to theatre, it got a little bit worse. I'm not sure.
Maybe. I mean, when you have patients who can't bear you to touch their skin because the pain is so bad, you think neuropathies. I guess, yeah, you do think of compartment syndrome, and what else could it could give necrotizing
Yeah,
fasciitis.
neck fash.
Um,
Yeah.
you'd have some sort of cellulitic changes, wouldn't you? Yeah. Are you satisfied with that diagnosis?
Uh, it's a difficult one, isn't it? Because I feel happy for the patient that he got a diagnosis and that he went to theatre and then he improved and his CK came down and his final CK on discharge was 400. So there was certainly some level of inflammation there in the muscles, and
Mm,
he never developed any kidney problems. So that's good. So he always remained having a normal kidney function with urea and creatinine. But what I can't reconcile myself with, and the same as you, is will playing one game of football cause that level of inflammation in the muscles, or is there something else going on that we need to think about?
mm. Well, it sounds like you thought of everything. I mean, they presumably would have they would have biopsied the muscle at the point of I mean, there would be some kind of histology outcome from the surgery, so that would show, you know,
Potentially, yeah, potentially.
so, any mycetic processes, and also, you know, glycogen storage diseases like McArdle's disease and all that
Mm,
sort of, which are very super rare causes of myopathies with the raised CK, though I've never heard it presenting at his age in that part of the body before. But
mm,
if we've closed the door on all of those, and we need to make our peace with the fact that this is an unsatisfactory diagnosis. Unsatisfactory to whom? Our listeners will be asking, to the patient or to us? And the answer is really, I don't know his thoughts about it, but it's to us. And what we're going to do with that? I mean, I think it's fascinating that you made the bedside diagnosis, Amy, and you hung on to it throughout, which was it's not often that a jobbing, general physician like us makes a surgical diagnosis like that in the absence of any imaging, and that gets the patient to theatre. So I think that's amazing.
I don't know where the diagnosis came from, whether I'd read about it, because it came to my head and I must have seen it or read about it somewhere, because it's not, something was in my brain that made me think about it.
Right.
Again, I'm not sure what that is. But yeah, it's an interesting, I mean, on the same day, it was one of those, isn't it, as well, where you're trying to deal with a very sick patient like this, and there's lots of other things going on. So throughout all of this that was happening, I'm still having to be the consultant of the day in ESTEC.
Mm.
And that's really challenging. I really struggle the older I get to multitask and to try and keep on top of everything and have oversight of what's going on. And, in a busy ESTEC, how can we, do you have any tips as to how to be on top of things when things get difficult, when things get busy?
Breaks. You
Right, yeah, that's true.
take your breaks. Everyone laughs at me when I'm saying someone said this to me when I think I was maybe a medical student. It was on my surgery attachment, and I was watching the consultant and the registrar do an operation. I believe it was a nephrectomy. And
Yeah.
the consultant was teaching the reg, and he said, and I don't know why it stuck in my memory, but he says, listen, in surgery, he says, when things start going wrong, slow down. If things continue to go wrong, stop. And it went right into my long-term memory banks, that statement. And I fished that out now. And it isn't just surgery. You can apply that to a lot of stuff. You can apply that to a busy ward round or a take, or anyone really. When things start going wrong, our instinct is to go faster and faster. Uh-oh, there are 6 people waiting. There's 9 people waiting. There's 12 people waiting. One of them's really sick. This one needs to happen now. This one needs to go home now. This one needs a review now. And we try to run around and go faster and faster. Look at traffic on the roads. When the traffic's bad, we try to go a bit faster and faster to make up time, and it actually snarls it up worse. When things start to go wrong, slow down. It's paradoxical, but actually you need to do that, I find, to actually be able to have situational awareness and focus on what needs to be done. If things continue to go wrong, despite you slowing down, stop.
Yeah.
Absolutely stop. Say out loud, we need to stop. I'm gonna go in there for 20 minutes and eat that sandwich, and I'm gonna come back, and then we're gonna deal with this. I'm gonna go and lock myself in the loo for 5 minutes, and I just need to put a physical barrier around my body, and we stop. And I say this a lot to people when I'm teaching simulation, when I'm teaching human factors and patient safety at work. And it runs counter to what I think we've picked up over the years, which is the busier you get, the faster you should go. Doesn't seem to pan out like that. it's more a case of slow and steady wins the race. What do you think?
Yeah, I mean, I had a really difficult shift a little while ago in SDEC for exactly what you've described. It gets busier, 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 and you go quicker, 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 and you become less effective. And I just completely broke down and became absolutely, utterly useless. I couldn't do anything because I was so overwhelmed. It was just too much. It was like, how am I going to see all these patients and how can I review all these patients? And it was just chaos. And what I should have done is take myself out of that situation. But sometimes you get into that situation so much, you need somebody to pull you out
Yeah,
and go,
you don't realize on the
Amy,
inside
yeah,
what's going on.
I didn't realize.
Hmm.
Yeah, absolutely. And one of the fantastic members of staff on the ward, she's like tracks the patients in and out, and she said to me, Amy, would you like a cup of tea? No, I don't have time for a cup of tea. Would you like a cup of tea? She just made me a cup of tea. And she came up to me and she said, why don't you just go and sit down over there? Just go and take a break for 10 minutes. So she didn't directly say, Amy, take a step away, you're acting like an idiot. She did it in a very nice way, actually. But I couldn't actually go back to work then for an hour. So what I should have done is prevented me getting to that stage, and took a 20-minute break instead of just working for 6 or 7 hours without, going to the toilet or anything. And having these preventative breaks, isn't it? Just 10, 20, 50 minutes.
Yeah.
Um,
But it's easy to say. It's the
it-
worst thing to say when you come in the morning and your night team look like they've been to hell and back.
oh, I know.
Not know
Yeah.
how busy it was. I did not stop all night. I haven't eaten. I've been to the toilet. And the worst thing for me to say is, why don't you just take a break? They'll punch me in the face. But they don't need to hear that right now. You do not know what it's like. And I get it. I
Yeah.
get it. I get it. I
Yeah.
grew up
Yeah.
in a place where I have no boss. There's no one above me who's going to shout at me for taking my break. Whereas, it's different when you're not at consultant level. But I think from a patient safety point of view, it's important to reprioritize breaks a bit higher than we currently do. What I find really
Yes.
interesting, though, is that you're saying you were having this really crazy shift. You'd lost the ability to multitask. What is multitasking really? We get down to it. It's basically continually switching your attention from left to right, left to right. You'd lost your
Yeah.
ability to do that. You were close to the edge. You couldn't even have a time for a cup of tea, and yet you still got the diagnosis and got the right team there and got the patient the ultimate
Mm.
treatment that they need. Now, I'm not saying this to flatter you or anything like that, but I think it's fascinating that you can do this to us, and yet we still get things right a lot of the
Yeah.
time. And where does that come from? I think it comes from the fact that human beings are incredibly adaptive and
Mm.
resourceful and capable. And you can actually push us, and God knows that our job does, to the limit of sort of psychological endurance much of the time. And yet 99% of the time, we do things right and things go the right way. We focus on the 1% that don't, but most of the time, things just tick over and they go well. We don't focus on that. And I think it's fascinating that, A, we don't see it. B, that we still manage to get things right despite all the barriers to getting things right that you mentioned. And C, that we sort of then feel culturally, well, we seem to still get things right despite being really, really, really busy. Maybe this is the new normal and it's okay. And we don't take breaks anymore. And that's how cultures become stagnated. And that's how you end up with the current generation, I believe, of doctors who are working a lot faster, harder, and more intensely than I did when I was at their stage, because things have gotten so busier and maybe we've taken our eye off the ball in terms of the basic needs about clinician well-being. What do you think?
100% agree with you. Yeah, absolutely. I 100% agree with you. I think we have a responsibility to the people who are sort of coming behind us to role model well. And role modeling means taking breaks, going to the toilet when you need the toilet, getting some fresh air when you need fresh air. And I think by me not doing that is actually negatively impacting on not only patients, but also those members of staff around me.
Yeah.
And I went away and reflected a lot about that shift in many different ways. I thought about the patients, I saw the patients I didn't manage to see, the patients I reviewed, the patients I didn't manage to review. There are so many questions. And then you go back into work the next day and then you do it all again and you have a completely different experience. And, So I guess the key takeaway point is number one, take a break. Number two, take a break. Number three, take a break when you can.
They're
Or
not luxuries, are they? They're not luxuries. They're patient
no.
safety.
Yeah, and I think we need to reframe how we look about it. We're not packing when we're going on a break. We are just refueling because we all need
Yeah.
to eat and drink. And we are, like you say, they are, by taking that time out, we are potentially going to be saving a patient's life because we are getting our cognition back to where it should be. So
Yeah.
that's a really good point.
And when we get
Anything else?
I was going to say, when we get the pushback saying take a break, and we get, what's the point taking a break? I'll just be frazzled and stressed, and I won't know what to do with this patient in 10 minutes' time, rather than being frazzled, stressed, and I don't know what to do with the patient now. And my answer is just trust me, take the break, just take it.
Mhm.
You will still be, you don't know what to do and you're frazzled, but you'll feel a bit better about it.
Yeah, absolutely. And it also, what I've noticed as well is it goes in like roundabout. So, my colleagues are amazing and they really helped me out that day,
Mm.
just with lots of different things and being really supportive. And I was like, are they going to think I'm a right twit? I can't cope, I can't manage. And then, other weeks it's me supporting them.
Yes.
So, we all support each other, don't we? We have good days, we have bad days. And the most important thing is having a supportive environment to work in where we all do look after each other.
I agree.
Yeah. Anything else that you want to say, Ben? Any other reflections?
No, very interesting case, even if we're not quite buying it, the ultimate diagnosis, but really interesting. Thank you for sharing that one.
Yeah. Thank you very much to everybody out there who's listening. Please continue to rate, review, and drop us an email or tweet us and let us know what you think. And if, you've got any suggestions of what you'd like an episode on in the future. Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.